اليوم عايدين بالحج.
هم اسمه بيعدي.
Assalamu alaikum, مساء الخير. Good evening everybody, my name is Ibrahim Sbeih, I'm a neurosurgeon and we are transmitting live from Farah Medical Campus here in Amman, Jordan. This is, if you want to visit Ibrahim, you will have a camel ride on your way to Petra, in which you pass through this slit between the rocks, the Rosh City, and then you'll find the magic of Petra, one of the world's 7 wonders. And this is Petra at night. Our topic for tonight is cerebellopontine angle meningioma, the clinical, radiological, operative, and pathological correlation. Harvey Cushing was the one who coined the term meningioma from meninges. And everybody thinks that the meningiomas arise from the dura. Actually, they arise from the arachnoid. Supratentorial much more than the infratentorial, 90% versus 10%. So most of the meningiomas are above the tent. The 10% below the tent are the most difficult. So we'll talk about infratentorial meningiomas, and among these are the cerebellopontine meningioma. So what is the origin of these meningiomas? You have to know some anatomy. And the anatomy of neurosurgery was not done by anybody better than Albert Rotem, late Albert Rotem. He's a great mentor, a great anatomist, a great surgeon, who was raised in Gainesville, Florida, in a poor family. He admits that. And one of the things that he always speaks about in his lectures, that if God created him at the time of his birth and he put a condition on him, telling him, Albert Rotem, I want you to go to school, medical school, and then become a neurosurgeon, and then do the best to be the best of the neurosurgeons. I want to get you one child with a brain tumor. I want you to remove his brain tumor, and then I'll take your life. So God is opening Albert Rotem that his study, his whole study, is just to save one patient's life. And Albert Rotem would say, I would have accepted. So we learned lots of anatomy from him. This is the inside of the skull. This is artificial skull. This is real skull. And the skull is made of many bones. The central bone is the sphenoid bone, but the most difficult bone is the temporal. It is the most difficult. And if you look at the temporal bone from the outside, if you take it out from the skull, it's a magic thing. It's made of 6 bones, and if you have the 3 ossicles, then it's made of 9 bones, 9 segments, 9 areas. So this is the inside of the temporal bone, squamous bone, petrous bone, and this is the image of it. This is the inside. Here is the temporal bone. So temporal is making a joint with the occipital bone. And the jugular foramen is a foramen between the occipital bone and the temporal bone. Again, central part is the clivus, here from middle and lower clivus, 3 zones. And there is an angle between the petrous and the clivus, called petroclavian angle. No one would appreciate this angle except the skull-based surgeons, because they know that every millimeter counts. This is a view I took with my camera when I was attending one of the Rotem courses in Gainesville, Florida. So if you just attend there, you will gain a lot. He's done now, but his center is still the most important cadaveric lab in the world. So this is the trigeminal nerve, this is the vestibular-facial nerve on both sides, and these are the lower cranial nerves. This is the medulla, vertebral muscle. It's a very complex anatomy. If you don't know that anatomy by heart, you should not be there at all. So this is the view. And this is just a close-up view on that side, on the left side. Trigeminal nerve and the vestibular and cochlear nerve going into the intermediate meatus. To do the surgery for the cerebellopontine, we'll be working here. So the knowledge of anatomy is of utmost importance. Brain surgery is not bare holes for subdural. It's not a disc prolapse. It's none of these. In this small segment of the skull base, every little important thing and essence of your life is there. All the cranial nerves are root there. This is the interjugular foramen with the glossopharyngeal vagus and accessory. This is the seventh and eighth, and here is the trigeminal nerve, and this is the sixth nerve, all within few centimeters. Again, the vertebrals, the basilar, the ica, the pica, cerebellar, cerebellar, the relationship with these neurovascular bundles. You don't remember them, you just memorize them and just encrypt them in your memory. Again, the trigeminal nerve in Meckel's cave, the internal auditory meatus with seventh and eighth, and the three nerves in the internal jugular foramen. In this set, jugular foramen, above it, internal auditory meatus. This way is the trigeminal cave, or Meckel's cave. This is the middle fossa, as you see it from there. And this is when you remove the dura, this is the trigeminal nerve. And this is the back of the clivus. This is the sixth nerve going into the Rollos canal. The Rollos canal is a story of its own to know exactly what's going on there. So you have here the internal auditory meatus with seventh and eighth, trigeminal going to Meckel's, fifth nerve, and this is the sixth. Each part of millimeter here is very important. So the tumors arising here, and you should know it. Again, when you go in, this is the trigeminal nerve, this is seventh and eighth nerve, this is the space between them, this is called the premeatal area, and this is one of the veins called vein of Dandy, or superior vitreousal vein. So, still, where is the cerebellopontine angle meningioma arise from? What is the origin? People say it's coming from the cortex, lateral group, suprameatal, inframeatal, premeatal, and petroclival. This is a very important paper by Sbeih about these so-called cortical cerebellar meningiomas, like this. So this is medial cortical, this is lateral cortical, this is outside petrous meningioma. In my series, I collected this for you. This is lateral for cortical cerebellar meningioma. This is outer petrous meningioma. This is meningioma that is arising lateral to the internal auditory meatus. Here it is reaching to the internal auditory meatus. Here it is centered over the internal auditory meatus. Here it has crossed the area into the clivus. Here it's sticking all of the vitreous area. These are my cases. Now, again, these are my cases. When they go berserk, they go berserk. So this is the meningioma centered in the internal auditory meatus. It crossed to the clivus and then crossed to the Meckel's cave. Here it crossed to the other side. Here it crossed completely to the other side. Here is something that you cannot describe or give it a name. So where is the petroclival meningioma arising from? People say if it is arising here, it's called premeatal, before the meatus, which is the internal auditory canal. Here it is called postmeatal, after the meatus. Here is the trigeminal nerve. So people are different. Do we consider this as petroclival meningioma, or do we consider it as cerebellopontine angle meningioma? So Majid Sami has to be mentioned here. Majid Sami has set the standard for the posterior fossa benign tumors. He is the most experienced neurosurgeon in the world with posterior fossa. He's a friend of mine, he's a friend of my family, and I'm proud of this friendship, and I learned a lot from him. Just to give you a hint about this man, he has done something like 5,000 acoustic neurons. So here he is. Visited Jordan so many times, visited my house. I visited his house and so on. He's a great man, a great teacher. Here is one of his hot debates. He fights for his opinions. here I'm visiting his center in Hanover. And the other man that should be mentioned with the posterior fossa is Takeshi Kawase from Japan. Again, he's a great friend of mine, and we are members of the same groups of skull-based neurosurgeons. This is our meeting in China, this is in Geneva, this is in Thailand. Again, we are members of the World Federation of the Neurosurgical Society, and we are members of the World Academy of Neurosurgery in Vienna. He's a great man, and he's a great adventurer. He came to Jordan, what did he do? He just took a car with his wife, Nikki, and he just went alone, without any guide, to Petra, to Wadi Rum, and he went hitchhiking everywhere in Jordan. So this is his habit. Here he invited us to his conference in Mount Fuji, and he insisted in doing the Japanese food. The other man that should be mentioned is Asama Mufti, a Syrian origin. He's American. He's one of the great members of the skull-based societies. He's a very honest man, a good man. So these people, they made our mind about these origins of the cerebellopontine ankle meningioma. To start with this paper from, again, from Bassioni and his colleagues in Eastern Germany, they said, let's look at the posterior vitreous or cerebellopontine ankle meningioma. They had 47 patients, and they looked at how many were before the detrimitous, or behind the detrimitous, or above the detrimitous or below. So in their series, the commonest number 19 is behind the detrimitous. But then came Majid Sami, 347 cases, the largest number of cerebellopontine ankle meningioma. And he classified them that most of them are pre-meated, before the meatus, which are the most difficult cases. So he wrote these many papers in the book about it, and this is a kind of pre-meatus, before the meatus. So most of the meningioma is in front of the internal meatus. So when you come from behind, from posterior fossa, you will find that the nerves will be on the back of the tumor. Different types of these tumors. This type, again, is centered over the meatus. Half of it in front, half of it in the back. And these are, again, one of the most difficult, because the nerves are inside the tumor, like in this way. So when you look at the pictures, you have to know where is the tumor in relation to these structures. So you have to be a radiologist on top of being a neurosurgeon. And this type is suprameatal, above the meatus. So this is the meatus, above it. The nerves will be below. Or infra, it is below the meatus. So each nerve will be in different position. Post-meatal, behind the meatus. And from there they can extend to the jugular foramen here, they can extend to the internal detrimitous, inside the detrimitous, and they can go everywhere, involving microscale. Lillian Shaker of Seattle, of United States, again a great skull-based surgeon, again a close friend and a member of these societies. He said, well, let's wait. If the meningioma arises from the vitreous ridge medial to the internal detrimental canal, this is not this is not cerebellopontine, this is vitroclival. So there is a difference there, but it is a minor difference. What about the images? What do we see on those images? When I do images, I'm interested in few points. I and all skull-based surgeons. This, ill-defined edges, multimedular. This is a very bad prognostic sign. I know that this case is going to be very difficult, and I wish I disappear or the patient disappear. But I don't like to operate on these patients. They are very tough. There's no plane of cleavage. Also, we look at T2. The darker, like this, the more fibrous, the tough it is firm. So you cannot manipulate it well. It is just like a rock. I also look for edema. If there is edema of the cerebellum and the brainstem, this is a very bad prognostic sign. It means that the pia has been bulgrated, so there is no pia. The tumor is inside the brainstem, inside the cerebellum. Another thing that I look at is the hydrocephalus. Hydrocephalus is a bad sign. I also look for bony invasion. In this case, it is post-meatal, behind the meatus, but it has invaded the bone completely. Look at this one. It has invaded the bone. What's the differential diagnosis of this? Any medical student, any resident first year of neurosurgery should know that the commonest, the three pathologies in the cerebellopontine angle are in this frequency. Vestibular schwannoma comes first, about 70, 80. 10, 15 is the meningioma, and then the epidermoid. But people don't think of the others. There are so many others, not only these three. Ask any radiologist, he will tell you these three. It's wrong. It's much more than this. Look at this. Facial schwannoma, jugular foramen schwannoma, lymphoma, arachnoid cysts, DNET, and epidermoid, as we mentioned. Chondroma, chondrosarcoma, endolymphatic sac, neurosarcoidosis, metastasis, and choroid plexus papilloma. Medulloblastoma going into the cerebellopontine angle. Teratoid rhabdoid tumors, especially in children. Meningioma, cholesterol granuloma. Aneurysm of the basilar or of the ankle. Clivoscordoma. Trigeminal schwannoma. Glioma. Look at this. It's a glioma. It's not acoustic neuroma, nor meningioma, nor epidermoid. Cavernoma. Last time we presented cavernomas. This cavernoma is done in the internal determinatus. The meningiocytoma and lipoma and glomus jugulare. So we have to stop just thinking in 2 or 3 pathologies. The pathologies are there, but we do not think about them. The commonest thing, as I said, is acoustic neuroma, so you have to differentiate between acoustic neuroma. These are all acoustic neuromas, and these are all my cases. This is the largest acoustic neuroma I came across. Very giant. So you have to differentiate between meningioma or schwannoma. Somebody may ask, why should I? Why should I bother? We have to do surgery for them, so why should I bother? You should bother because you have to discuss with the patient and the family what are the prospects of healing, the facial, prospects of life, prospects of recurrence, and you have to be prepared of what you are going to face inside. What tools would you do? So it is not just a mental exercise, it is actual exercise. So there are points that differentiate between meningiomas and schwannomas, the broad contact with the vitreous bone, with the tentorium, where center is away from the internal canal, many items that can differentiate. You may need to do angiography, and I do in cases of giant tumors with vascular, so you get to know what is the pathology, what is the vascular blood supply, and you may go and do embolization. You should do venography. This is very important. I just don't understand anybody asking for just a brain MRI. Brain MRI should include brain MRA, should include brain MRE. If you don't include that, you are not a good surgeon. In fact, you should stop practicing. Here in this view, superior sagittal sinus, straight sinus, transverse sinus, sigmoid sinus. This is for any medical student. But here, you have to see where is the cavernous sinus, where is the superior temporal, superior petrosal sinus, where is the inferior petrosal sinus here, and where is vein of Labé. If you want to operate on those structures, you have to know. And this is the most serious of all, so-called occipital sinus. If you are not aware that there is occipital sinus, you may kill the patient without knowing. And most of the time, venography and angiography are reported as no aneurysms and no AVMs, which is a silly statement, to say the least. So you have to know all these veins, and one of the veins that you come across always is the cerebellopontine vein, the vein of Andy. Sacrifice it or not depends on so many factors. Again, the beauty of the venography, look at this. The cavernous sinus, the inferior pterygoid, cerebellopontine vein of the vein. All this is essential anatomy knowledge. It is not a luxury, it is basic neurosurgery. And again, Albert Rotem, God bless his soul, he died a couple of years ago. And I remember we were together in Sharm el-Sheikh on a boat trip after lecturing. And he actually challenged everybody on the trip, how many press-ups can we do? He was 90 years of age, and he won. He has done 140 press-ups. So he wrote a lot about the relationship of the petrosal vein with the severe petrosal sinus. Again, another man who done a lot of these is Osama al-Mifti, again about vein of Lavey, and its importance. So you may need to do embolization, we discuss that. I don't do it unless I have to, and most of the time I don't. But this is one case we did, and we embolized this meningioma. This white stuff is the embolic material inside the tumor. Meningiomas of the internal determinatus. So don't say that because this lesion is inside the internal determinatus that it is acoustic neuroma. This is a case report that has been published, and this was a meningioma. And in another case, there were two, acoustic neuroma and meningioma, acoustic neuroma and meningioma, both in the same place. I had the pleasure of having two twins, the trigeminal schwannoma and acoustic neuroma. How do they present? Hearing loss, vertigo, headaches, trigeminal neuralgia, cerebellar signs, but rarely facial weakness, like the acoustics. But here is cerebellopontine meningioma presenting with hearing loss, because it's centered over the internal determinatus. How do we manage these cases? Observation, surgery, or radiation. Let's discuss. I only observe these cases. This is one case we had about last week, young lady of about 39 or 40, who was accidentally found to have this meningioma. Examining her, she had nothing, and this was discovered accidentally. So this is a place where you wait and observe. If it is a small, asymptomatic, if you find it incidentally, and if the patient is medically unstable and asymptomatic. So surgery is the mainstay. Complete surgical removal is the optimal treatment. But this should not be achieved at the expense of the patient's life and the quality of life. You should not be brave on the expense of the patient. You have to be honest. You know or you don't know. And most of the time, most of the neurosurgeons don't know. Yet they operate and kill patients. Let's go back to Kawase. He started this business in 1991. He discovered something called Kawase triangle. And he would tell you that he discovered it accidentally. He said, I was lost during surgery. 1991, he was still young. He was lost during surgery, and he discovered this area of bone which is devoid of any important structures, and he called it Kawase triangle, which is this one, Kawase triangle. If you drill that, you can go to the posterior fossa. So I wrote so many papers on this approach, many papers which I enjoyed reading. I read 3 journals every month because there is a paper published in neurosurgery every minute. Do we ask residents during residency program to write papers? No, it is not a condition in Jordanian board or the other board. There is no need for the neurosurgeon to write papers. So you are producing very non-elegant neurosurgeon. Sbeih from Germany also use the sitting position or semi-sitting position. Al-Mifti again. he described what's called the Bermuda Triangle. This is the Bermuda Triangle. The word angle where the vein of Sbeih joins the transverse sinus and the sigmoid sinus. This is the Bermuda Triangle. You don't, or you do know. Most of the time, most of the neurosurgeons don't know. William Caldwell from Salt Lake City in USA, he's the past president of the American Association of Neurosurgery. A close friend of mine, he wrote this paper about his experience in 109 cases together with Taka Fukushima from Japan. So he said, anything, this is a trigeminal nerve, this is intervertebral meatus, this is the jugular vein. He said, if you draw a line like this, anything medial is petroclival. So surgical approaches varies according to the size, the location of the tumor. Just to go through them quickly, this is called anterior transpetrosal or Kawase triangle, Kawase approach, which I mentioned, or posterior petrosal, which was championed by Salman Rushdie after Hakuba. Pre-sigmoid also, it is one of his achievements. You go before or pre-sigmoid. And the workhorse is the retrosigmoid. I've tried the other approaches. I love the retrosigmoid, and I learned from Majid Sami that you can reach any tumor in the posterior fossa with this approach. So here you are, retrosigmoid approach in all cases, semi-sitting position. This is another approach of Salman Rushdie. And this is Anil Nanda from Louisiana, Shreveport. He's a very seasoned skull-based surgeon, and he would drill the bone behind and anterior to the intervertebral meatus. Radiosurgery. Many times I just said that I have brought the camera knife back in 1996. I'm proud of that, to bring a new machine to Jordan. We were the first in the Middle East, 1996. But I always believe that a fool with a tool is still a fool, not because there is a machine that you have to use it. It has certain indications. Use it properly. Pity that lots of people are using it because they cannot operate. So they treat anything and everything as if somebody is holding a hammer and he's hitting anything, because he doesn't know what to do with it. This is very irritating paper, written by Douglas Konziolka. Douglas is a friend of mine, but we differ a lot. We fight and shout at each other, but we respect each other. He respects me and I respect him, but I disagreed with him on this one, and I made my point very clear. He says, is there a place for microneurosurgery? Today, neurosurgeon must consider the option of both surgery and stereotactic radiosurgery, where no histological confirmation is obtained. So this is controversy. You say that there is no histological confirmation, so how would you treat things that you don't know what it is? So he said it is time to consider radiosurgery as a primary management. This I differ with completely, and my voice is now here for all our international audience. I disagree with radiosurgery as an upfront treatment for these tumors. His boss, Dave Lansford, about 10 years later, 2014, wrote this paper. The section is the first line option for cerebellopontine meningiomas. However, during the last 20 years, stereotactic radiosurgery has become an alternative option for CP. I agree for an option for the old people, for the ones that cannot go for surgery. So it is an option, but it is not a primary treatment. And why? Because radiosurgery and radiotherapy, they have many, many complications, including producing the new neoplasms. And I have done my homework and collected the malignancies that occurred after the gamma knife. My series of cerebellopontine angular meningiomas, 49 cases, confirmed, followed up, because there are more. So you may have 100 cases, but the ones that you followed and you have documents are 49 cases. If somebody says, I have 100 cases and I follow them up, he's a liar. So this is example of these cases with this edema and all these pictures that I showed you. Again, this is my collection. I'm going through them quickly. These are the cases so many years. Various types, pre-meatal, post-meatal, meatal, you name it. This is one of the cases, pre-meatal, and when you go in, this is actual case of mine, 59-year-old male patient. When you go in, this is the facial nerve, and this is ICA, and the tumor is ahead, in front, pre-meatal. Most difficult, because you have to go above the nerve and below the nerve, between the facial and the trigeminal, between the trigeminal and the third, and so on. You will work in compartments. So this is what we did. We work in compartments. At the end of the day, sixth nerve is here, trigeminal nerve is here, facial and vestibular are here, the three nerves, plus the pharyngeal, vagus, and accessory are here. Beautiful. No radiation, no misery of radiation. This is sixth nerve, as you see here. Another case, again, pre-meatal, this is facial and ICA, this is the tumor there. So you work between the facial and the trigeminal, and you work between the trigeminal and the third nerve. You can see the pituitary stalk. You work between the facial and the lower cranial nerves, and so on. Some of the cases that we have done, 52-year-old female patient with this tumor, and this is the post-operative, and this is her before, after, and follow. Another case, 49-year-old female patient. Notice that meningiomas are more in females, which is obvious because of the hormonal status. We have prostate problems. Another case of this very, very difficult case of this centered over the interdigitatus and postoperative and the follow-up. Another case from Emirates with this tumor being removed. So my collection is 49 cases, gross total resection 38, and this is corresponding to Simpson grade 1. Follow-up very, very long, up to 176 months. Mortality, I had one. I lost one patient. Morbidity, where we are. If anybody stands and said, I have done 100 cases, I did not have complication, he is a liar. So I had 3 recurrences. So we come to our case, cerebellopontine angle meningioma, presentation of this case. This is a 62-year-old female from Iraq. She complained for 3 weeks from coming to Jordan with headaches, blurring of vision, then had double vision, and she had decreased hearing in her right ear and right-sided facial weakness and spasm, hemifacial spasm. Her face was flickering, just like doing all sorts of movements. Right-sided facial hemispasm, which means that the facial nerve is irritated. Hypoglycemic and hypertension, hypoglycemic, sorry. She had lap cholecystectomy, vital signs are okay, general examination was okay, neural examination 15/15. You will see that she has a large tumor, but her Glasgow Coma scale is 15/15, which again stresses the point that the Glasgow Coma scale does not represent everything. The Glasgow Coma scale is for coma assessment, not for a neurological assessment. She had dysarthria. Dysarthria that her speech was cerebellar, no, just like that. So this is cerebellar speech, not aphasia. She had right-sided hearing impairment, and there was no weakness, 5/5. And today, one of the residents called me about a patient, and he said he had weakness. I said, what is the grade of weakness? He said, it's simple weakness. I said, what is the grade? He said, 2/10. So that resident does not know how to assess power, and he is in charge of patients. I will not mention names, but this should not happen. So she was ataxic, and she had free controls at home. This is herself. Eye movements are okay. Up, left, right, down, etc. Facial nerve is intact. No weakness. CBC, bleeding profile was normal. Kidney functions, electrolytes were normal. Liver functions were okay. Chest X-ray, ECG normal. Let's come to images. Immediately you would see that there is a large tumor here. This is without contrast. Pressing the pons and the midbrain severely. Would you believe that some people will give gamma for this? This is a criminal act at its best. Because with the brain stem compression, with the announced result of gamma knife, that you will get the result after 2 years, so you will leave your patient under this compression for 2 years. And the best you can get is to keep the tumor as it is, or slightly small. They don't tell the patient that if the tumor did not respond to the radiation, he will need surgery. And if he does need surgery, surgery is impossible. It's 100 times more difficult. Money, money, money. Press a button. You are not a surgeon. They call themselves radiosurgeons, and they do nothing of surgery. Some of people lost their ethics completely, and they treat these cases with gamma knife. This is with contrast. And you can see the tail. Tail is more in the meningioma, but it is not pathognomonic. You will see tail in TB, in neuropsychosis, after radiation, after infection, so many. Look, pressing the cerebellum, pressing the pons, almost reaching to the clivus. Look at the edema. We mentioned before that edema is one of the prognostic bad factors, bad results, bad surgery, bad tumor. When you have this edema, because the pair of the brain tissue has been vulgarated and invaded. Look here, we have gone through the tentorial hiatus, which means that major arteries are involved. There is hydrocephalus. So all the bad criteria of this lady is there. Here you would wait for that you disappear, or the patient would disappear, but nothing did happen. She did not move. I was not selected to go. So, again, look at the edema. Horrendous. Here. There is some restriction, which means that it is very cellular tumor. CT scan showed some calcification. And when you see calcification, it is more of a meningioma. You can see the calcification there. There. Again, the edema, the calcifications. Look at this calcification. Not only calcification, but invasion of the vitreous wall. The vitreous wall is invaded. Look at this. Very horrendous. And people, I know of people like this, have received the gamma knife without any accountability, because we do not have accountability. Look at this. This is coronal with the contrast. You can see how much of the brain stem is involved. And the edema, the destruction of the calcification and the destruction of the vitreous wall. The contrast sagittal, the calcification, and this is the spectroscopy showing that there is a peak there, which may denote that this is a meningioma. The MRA, which is essential part of MRI, you should not do MRI, you should do MRI, MRA, MRB. The three are one unit called magnetic resonance image of the brain, of the arteries, and of the veins. Look at this. This is the posterior cerebral artery and severe cerebral artery being pushed, not a tumor. And you would get a report saying, no aneurysms, no AVMs. What a silly statement. As if the angiography is done for aneurysms and AVMs, which are only two drops in the ocean of the pathology of the vascular disease of the nervous system. Venogram to show the venous sinuses. We did a few consultations. We consulted Dr. Mahmoud Asad for this lady with the right hearing loss. Mahmoud, are you around?
Yes.
Can you please comment on this? Because I see that she has a problem also on the left.
Yes.
She has a tumor on the right. So what happens?
Well, nobody can say that the right side or the deafness on the right side is caused by the tumor, because we have two, but right is more than the left. If it comes to me alone, without seeing anybody, I will ask for MRI, without MRI. But this is if there is any difference between sensorineural hearing loss from one to the other, we always ask to make sure that there is no brain tumor. The next thing is the impedance and reflexes. Can you see? So yeah, because we always do that. The most important about for us is the stability reflexes. And stability reflexes it's not a diagnostic for meningioma from the schwannoma, but it gives you a clue, because the reflexes, the sound goes by the 8th and comes back by the 7th. And if it is a schwannoma, it's most likely that the reflexes will be disappear. So if this one, the reflexes is normal, this can tell you that it is not schwannoma, it's mainly meningioma. If Dr. Ibrahim allow me to say something in the past, because if you know the past, you can appreciate the present and then you can look forward for the future. In the past, before we have CT and MRI, we usually have, the neurosurgeon send us some people who suspect that there is some tumor. And the only X-ray they have is the tomography, which is the main thing. So we used to do a lot of tests to try to differentiate between cochlear and retrocochlear. We do the stability reflexes, sometimes we do AVR, sometimes we do CC test, loudness balance test. All that is just to make sure that it is a cochlear or retrocochlear. Unfortunately, at that stage, it's a very early detection of schwannoma. But at that stage, it will not show in the X-ray. So no neurosurgeon can dare to go for this difficult place without seeing a tumor. So the result is just observe. Thank you.
So she had bilateral hearing impairment, which most likely is due to sclerosis, but maybe more because of the pressure of the tuning. We consulted Dr. Kamil Tokan. Kamil is he around? We asked him to come over, but we asked him to see the patient because she is hypertensive and he did an echo for the patient and ECG, and he announced that the patient is a low risk for surgery. Dr. Muhammad Juma, is he around? No. Again, we asked him because, as I said, for the using of steroids in this old lady. And of course, Dr. Farah Sbeih as the anesthetist in charge here in this hospital. And he says that she will be in GA, invasive monitoring. So we had the consent for the lady, which was extensive in Arabic and in English. Just in case somebody says that we did not mention it. It says everything, what she has before surgery, what is the aim of surgery, and we say the last line, which you cannot see, I read it. The aim of surgery, this is a commitment. I am telling the patient, the aim of surgery is to remove the tumor completely. But this depends on what I will face during surgery. So I am committing myself in front of the patient family. My aim is total excision of the tumor. So we will use the sitting or semi-sitting position. We may use all the gadgets we need, the navigation and the neuromonitoring. This is some of the pictures in our theater. Using the latest microscopes, we have Canivo in this hospital, which is the first microscope in the Middle East of its kind. As I said, we use the neuromonitoring for all the cranial nerves. And we'll do it in the sitting position. We use this curved sort of lazy C kind of incision, and remove this part of the bone. So to speak more about the semi-sitting position, I call upon Dr. Farah Sbeih, the chief anesthetist in Farah, Germany.
Good evening, ladies and gentlemen. Thank you, Dr. Ibrahim. We can't thank you enough for these presentations. I'll be speaking very briefly about the semi-sitting position in neurosurgery, because this is of utmost importance to our fellow, not only for our fellow anesthetists, but also for the nurses. Is anybody here from the nursing team? Yes.
Additional Sayyid Ali Khayes, who's the head of the operation theater. For Senate, you are here, there are no nurses whatsoever. In spite of so many reprimanding these, because we speak about teaching nurses, and if they don't learn, they will not serve our patients well. This is the 6th time in succession that not a single soul of the nursing department comes. Either they are superheroes in nursing, or they are extremely ignorant and arrogant.
Now, just going back to the lecture, so this position improves surgical access to the posterior fossa. So we try to make the life of surgeon much easier, even though this position requires very meticulous work, very hefty, and being detail obsessive, and also we thrive always for perfection. And this is one of the most difficult positions in anesthesia. This position has many advantages. As we said, it improves the surgical access. Not only that, it has better surgical teaching, and also it improves the venous drainage from the surgical field, better hemostasis, and the list goes on and on. And what's important for us as anesthetists, it improves the access for the tracheal tube, the chest wall, the arms, so the anesthetist could observe his patient during the operation, as well as also the importance of the respiratory physiology, as there is a free diaphragmatic movements as opposed to the supine position where all the abdominal contents press on the diaphragm, and also the shorter surgical time as compared to the other positions, especially the prone position, and it decreases the intracranial pressure. Now this position also does not go without complications, and this position has many complications that are actually documented and mentioned in the literature. Most importantly is the cardiovascular instability, because we put the patient under anesthesia in semi-sitting or completely sitting position, so there's venous pooling. So the patient would suffer hypotension in the beginning when we put the patient in the semi-sitting position. That's why we have several measures. If I can have the pointer, Dr. Jamil. So if you notice here that the legs should be almost at the level of the heart, this actually enables the venous return to the heart. And also we use pneumatic devices. It also it helps the venous return to the heart. In addition, when you level the legs at the level of the heart, this is actually very important during surgery, because one of the major complications is venous air embolism. And putting the legs in this position would actually help to decrease the gradient between the legs, the surgical field, and the right side of the heart, and hopefully in the hope that we decrease the incidence of venous air embolism. As you can see, the venous air embolism, it's mentioned in so many papers, and the incidence might go up to 40%. One of the major complications as well is pneumocephalus. We might not notice it intraoperatively, but we actually notice it in most cases postoperatively. That's why I wanted some of the nurses to be here, because clinically the first sign would be agitation and confusion, and this is a very ominous sign for pneumocephalus. So immediately the surgeon has to be informed, because the patient has to go immediately to CT scan. So because if a pneumotension would develop, the patient would develop a brain herniation. In addition, there is a major complication that we suffer as anesthetist, macroglossia. That's why we have to take care of the positioning. So we would make sure that there's a complete venous drainage from the both internal jugular veins. So we keep 2 to 3 fingers between the chin and the internal jugular veins. And God forbids that sometimes patients, if they move during surgery, they might, because their head would be held on the pins, they might suffer from quadriplegia. So preoperative evaluation is of utmost importance to anesthetists, and they should evaluate the patient and should know every single detail about their patients. So thorough preoperative evaluation of the neurological condition and the cardiorespiratory status is extremely important. So routine assessment of coexisting medical condition and review of optimization should be performed. Now, a major issue in these cases, especially in the performing posterior fossa surgery in the sitting position, is the question of patent foramen ovale, because the prevalence of patent foramen ovale in the normal population is around 25%, and it might go up to 40% in those with cryptogenic stroke. So, in addition to that this patient had hypertension, and that's why Dr. Kamel was consulted, he did an echocardiogram. We as anesthetists, we almost always request in this center an echocardiograph in the sitting position, so we would rule out the presence of patent foramen ovale, so we would avoid the paradoxical air embolism. So intraoperative monitoring, I just summarized it as routine monitoring for us, but it includes arterial line, which is mandatory in this case, as well as the central venous pressure monitoring, not only for pressure monitoring, but in case, God forbid, that you have a venous air embolism, an immediate action would be by informing the surgeon who floods the field with the saline, and we aspirate air through the central line, and then we make use of the tilt of the Trendelenburg. In addition, monitoring of venous air embolism. Now, the most sensitive is transesophageal echo, but this is a semi-invasive procedure which we try to avoid, as well as it's extremely expensive and costly for the patient. In addition, as Dr. Ibrahim mentioned, we use neurophysiologic monitoring, and the use of these monitors require modification of the anesthetic technique. So these modifications include, not to mention all of these modifications, but some of it is maintaining consistent and modest levels of inhalation or IV anesthetic, because it affects the monitoring, and avoidance of neuromuscular blocking agents, even though it's very challenging in this position, because, as I said, in any movement during surgery would cause the patient a quadriplegia. And in addition, the use of total IV anesthetic during the motor provoked potential monitoring. Post-operative management, extubation would depend on the pre-operative condition of the patient, and the presence of lower cranial nerve dysfunction and potential for aspiration pneumonia may warrant post-operative ventilation. And that's why we stress to every patient before they go to surgery that they might need post-operative ventilation, and they sign this on the consent form. Extensive intraoperative dissection, particularly in the floor of the fourth ventricle, also might warrant post-operative ventilation. ICP monitoring should be considered if post-operative ventilation is required, because hydrocephalus remains a risk, and that's Dr. Ibrahim always uses an extraventricular drain. And it's of utmost importance that the nurses in the ICU should make sure that they know what they are dealing with, especially the extraventricular drain, because if the level of the, as Dr. Ibrahim mentioned in previous lectures, if the level go below the patient head, you might kill the patient. Postoperative hypertension should be carefully managed to avoid bleeding complications postoperatively. A very challenging side effect of these kind of surgeries and the drugs that we use during anesthesia is postoperative nausea and vomiting. And some of the patients really suffer quite badly of this complication, so this should be managed quite aggressively. That's why we actually use multi-drug prophylaxis for postoperative nausea and vomiting intraoperatively, and postoperative nausea and vomiting should be treated aggressively postoperatively, and all patients undergoing surgery on the posterior fossa should be considered to be a high risk for postoperative nausea because of proximity to the vomiting center of the surgical locale. And thank you.
Again, here I want to point out why we ask the nurses to be here. We mentioned 3 points that are very important. They are life-saving for patients. That all these patients in the sitting position, even in the supine position, they will have some intracranial air. Obviously, when you are sitting, more of the air will come in. This will cause severe irritation and it may cause herniation. If the nurses don't know this, they will call the ICU doctor and a morphine or betadine will be given, and that will be the end of the story. So here we are, no nurses to know this important knowledge. Nausea and vomiting, how important they are. So, anyway, question?
Before we go to the appreciation. Now, this is the reason why we oncologists insist on getting maximum excision of a lesion like this, despite the fact that it really looks like meningioma, is the incredible differential diagnosis that we're going to discuss. And this is another reason why we insist upon removing this whenever possible, to the maximum limit possible. Not only would this be the best chance for the patient for excising this, and the best shot is the first time around. But if you get it wrong, the results would be disastrous. So if this is a schwannoma, that's not going to be a big deal because the patient would have probably been treated properly with radiotherapy had they been subjected to it. But if this is lymphoma, the patient would have been denied a curative treatment that would have been totally medical. And nobody would have guessed that this would be lymphoma. This would be an extremely atypical presentation for a lymphoma. This would be an either primary sense lymphoma or a secondary sense lymphoma involvement from another place of the body. Chondrosarcoma would be treated radically differently. Apart from surgery, these patients don't respond to chemotherapy or anything of those natures. Metastases cannot be emphasized enough because these patients are subjected to surgery with nobody having had the proper evaluation, and you would get patients with breast cancer because nobody bothered to do a breast examination, but are subjected for a cranial radiotherapy and nobody ever examined them. These are actually true cases. These are actual cases that underwent surgery after having excluded all the other problems as well. Ependymoma is treated after surgery with radiotherapy and then a platinum backbone of chemotherapy. Medulloblastoma is also treated with maximum excision, radiotherapy, and possible platinum-based radiotherapy after that. Gliomatous tumors would be subjected to radiotherapy after the chemo with an alkylator, plus minus. And all of these are actual cases. And all of these, they would have had the evidence buried with one form of modality of radiotherapy or another. And I cannot emphasize how frequent this, not only mistake, this crime happens. It happens on a daily basis, and we face this in our weekly our daily consultations on a daily basis, not only on a weekly basis.
Thank you. Did we have patients in Jordan dying because the nurses did not know how to manage the external ventricular drain? Yes. Many patients died because the nurse thought of this as a drain, and they just put it on the floor to drain more, and the patient died in his bed. So what we say is very important. Now what we will do is to be piece by piece, because we don't have the luxury of doing anything else. The ultrasonic aspirator is being used at the maximum power, which is 100%. Still, it could not take the tumor out because it's very, very solid. It's very, very firm. Now there is this vein or artery that is going into the tumor and coming down. You preserve it. It will take half an hour or maybe 1 hour to separate it from the capsule of the tumor, but it's worth it. So it is another word for those Speedy Gonzales in neurosurgeons. There is no Speedy Gonzales in neurosurgery. You know Speedy Gonzales, the rat in the comics? Now runs quickly. Some people think that in neurosurgery is a quick procedure. They should leave the profession for another thing, maybe in a garage, a mechanic or something. This took 11 hours of hard work, meticulous work, going every millimeter level. You can see the facial nerve. You have to preserve it, preserve the arachnoid, preserve the arteries, preserve the veins, otherwise your surgery will be failure. This is again trying to separate that vein from the capsule of the tumor. This surgery shortens your life. That's why neurosurgeons die young. So once you have gone around the tumor, you are assured that you have preserved the nerves, you remove the last piece. Compare the 2D with the 3D to see what we mean by the 3D would teach the residents, it would teach everybody what is going on. So I'll remove the tumor back. Now what I do is what my residents call a theatrical action. I just put it back to show you that we have removed it. Just theatrics. I will show you that the cerebellum was not compressed. Again, this is a word for the novices who don't use retractors because they don't want nonsense. If you use a retractor properly, it is not actually retracting, it's just holding things in place. Look at the cerebellum without retraction, it's staying there. So for those novices and the Speedy Gonzales, I say go home. Don't practice neurosurgery. This is the fourth nerve. This is cerebral artery, facial nerve, and cochlear nerve. This is vagus and its three nerves, the glosopharyngeal, vagus, and other. And this is the trigeminal nerve. We have preserved every vein, we preserve the nerve, preserve the cerebellum, and I close the dura with this artificial dura so that make it baggy closure. Okay. Histology.
So marvelous to see surgery in 3D. It looks like you are operating myself. This case was simple regarding pathology. You can see how the cells are mostly hypocellular, collagen bundles, some monomers bodies, and some slightly cellular areas. But you can see why it was very difficult to cut through the tumor, because it's mostly collagen, fibrous tissue. Next slide. You can see there is some monomers bodies and many fibrous tissue. And in this area, almost it's acellular, indicating so much dense collagen. Next slide. Here again, you can see how much hypocellular and very wavy. And you can see them, they are running in almost one row. And this is why we call this fibrous meningioma. Different from the whirling pattern that we see in meningothelium meningioma. This next slide, you can see how they run in fibrous patterns. This is typical of fibrous meningioma with many collagen bundles. Next slide. Again, here is almost, it's acellular here, it's mostly collagen bundles with a few cells. Again, next slide, you can see the collagen bundles and the spindle cells running in one direction. There is no atipia, no mitosis, no hyperchromasia. Next slide. You can see how all this is collagen bundles with very few nuclei and very few cells. That's why it is really mostly, it's a hypocellular, it's mostly fibrous tissue. It's very difficult to cut in a spoon. This is epithelial membrane antigen, it's positive. Next slide. Progesterone was positive, and this is indicate benign tumor. Next slide. B53 was completely negative, and T67, as expected, is less than 1%. So this is by histology is a benign fibroepithelial fibrous meningioma.
So, this is fibroblastic meningioma grade 1, benign. You excise it completely, end of the story. Patient is well. Why should you use radiation? You use radiation because you are a mediocre surgeon. 1 + 1 = 2. There is no other explanation for it. I remind you of this paper that we discussed last time, that it was published in the American Academy of Pathology, done by Farah and myself. We discussed the tumor size and the atipia, and we looked at the small cell component and the brain invasion, and the bone invasion and necrosis, the mitochondrial count, mitotic count, the P53, all the parameters, P63 and progesterone, Ki67, and we came up with conclusions. So we are active in our publications. I just want to tell you this. We are one of the few centers around the world using the semi-sitting position. We are expert on this. The other people don't use it because they don't know how to do it. And they use the supine or park bench position, saying that there is air embolism in the sitting position. I tell them there is air embolism in the supine position. But with the anatomy in front of you, you don't have to imagine. You know your anatomy. CSF blood is flowing down. It's easy surgery. You don't need a suction. You don't even need an assistant. Post-operative course, she made very good recovery. She woke up on table. If she didn't, we would have sent her to X-ray to see what's the procedure. No patient is put on a ventilator. This is a bad habit and this is bad practice, and lots of neurosurgeons in the Arab world, in Jordan, Arab world, and the underdeveloped world do it using this. Keep the patient on a ventilator so that he would rest for overnight. He will rest forever. Post-op. This is without contrast. So this is blood. This is after contrast. Blood is blood, so there is no tumor. This is blood, this is blood. Without contrast, with contrast, blood and blood. No tumor here. No tumor here. And the brainstem is okay. So, if a Speedy Gonzalez would have done it, he would have removed part of the tumor and went out and sent the patient for radiotherapy. Because that's what they know, press buttons. We put external drain, we removed it a few days later. Again, if there were nurses here, we would have discussed and told them what is the value of the external drain. But they are super nurses, they don't need to know more. So this is the patient, and the ICU and the room. Following day, and she came to my clinic for removal of stitches. This is the discharge summary, detailed discharge summary, many pages. And this is the follow-up MRI, about 6 weeks after surgery. Again, there's nothing there, no tumor at all. Midbrain is free. Bones midbrain are free. Now, no ischemic changes whatsoever. We have not damaged any neural structure, so it can be done. Those who are sent for radiotherapy are those who are dealt with by mediocre surgeons who do not know how to do the surgery. They are taught just to do burr holes for subdural and to do disc surgery and putting some barrier frames and so on. That's what they know. This is what the neurosurgery is for. Plates and screws. Like a carpenter. So this is the lady, no cranial nerve deficits, no facial weakness, her hemifacial spasm completely disappeared. And I have to say this is a big thank you for all members of our team. I could not have done my job without the help of all these people. My secretaries will really work hard. They will really work harder than I to prepare this material for you. So I thank you very much, Ahmed and Musab. And every member in the team of the hospital, emergency room, and the infection control room, and the lab, the residents, the nurses, the radiology department. If some of you has not have not been pictures, because when we took the pictures you were not there, but we acknowledge your help, and of course our excellent anesthesia team. Thank you, Dr. Farah and Gibson. Any questions, any comments, please?
Just to emphasize to the trainees in the audience, there's nothing benign about a benign brain lesion. Meningioma technically is a benign brain lesion. If not dealt with properly in the first go, these patients are doomed to a horrible course of recurrences that would eventually lead to a miserable demise. Not only demise, miserable demise. If you don't do it properly the first time around, you can't patch it up with radiotherapy and repeat surgeries later on. Chemotherapy basically does not work in this modality. There are a lot of things that we can do, but bottom line, they don't work. If these patients don't get the first chance properly the first time around, they're doomed to a miserable course. And this applies not only to malignant brain tumors, to benign brain tumors. I cannot emphasize this enough. There is nothing benign about a benign brain lesion.
I must say this, that to work in a place where you have everything there for you, the latest theaters, the latest microscope, the latest instruments, speaks of the administration. So thank you, Dr. Sanan, Mr. Karam, and your dad, who is the pioneer of medicine in the Middle East. Any comments or questions? Recurrence in these cases?
Yeah.
In my series, I had 3 recurrences out of 49.
What's the cause?
Because we don't achieve what we call Simpson grade 1. We call it a gross total. Because to achieve gross total, you have to drill the petrous bone. If you drill the petrous bone, you will kill the hearing, you will have CSF leak, etc. So there is this chance of one little cell there that can come back.
Capsule. The capsule. How to make sure that the capsule...
We have removed the capsule, but the attachment هي زي العلكة اللي حطيتها على الحيطة، بتقيم العلكة باسمها لها قبل ما ننزلها.
What to do?
You may operate again, you may give radiotherapy, or you may observe. What I do if I have recurrence, I wait, I observe. If the recurrence grows bigger, then you have the 2 options, operation or radiation. But not up front. Never ever send the patient for radiosurgery up front. Never. No more questions, no comments. Thank you very much.
Thank you very
عيد
much.
سعيد، كل سنة وانتم سعيد.